Okay, with that, let's go to some of the presentation. Typically, these individuals present with a sudden explosive onset of edema, hypoalbuminemia, and they often have very large amounts of proteinuria. Membranous nephropathy also typically has a large amount of proteinuria. We'll contrast that with FSGS, particularly secondary FSGS, in a forthcoming conversation. You may have learned as a medical student that, if you have nephrotic syndrome from minimal change disease, you shouldn't have any hematuria. But this is a common finding in all of the idiopathic nephrotic syndromes. Remember, idiopathic nephrotic syndrome captures 3 diagnoses: minimal change, membranous, and FSGS. So when I'm using that nomenclature, I want you to follow along. Again, those idiopathic nephrotic syndromes commonly have microscopic hematuria. I've presented it that way in the Venn diagram as well as we looked at the overview of GN. And then, you're often assuming that minimal change patients are not hypertensive, but here's some statistics to share that minimal change disease can also present with hypertension as a feature as well. Okay. In general, the prognosis of minimal change disease is quite good. When you see CKD in minimal change disease, often it's because of chronic calcineurin inhibitor induced CKD. We have a couple of those patients in our GN clinic. So they have childhood onset minimal change disease with frequently relapsing course. They've been on calcineurin inhibitors. They develop progressive CKD from that. Generally speaking, the long-term renal function of minimal change is quite good. Now, when we characterize minimal change and FSGS, so prepare your mind for that conversation as well, we typically describe these individuals as in terms of steroid responsiveness and dependence. Okay, and so I'm presenting that the same way here. And I've already said that if you have a steroid-resistant minimal change disease, then you probably are working with an undersampled FSGS. So I've made that point here. These are less likely to be true minimal change, but rather an undersampled FSGS. Okay, at least that's how I manage them. Okay, I don't even call them minimal change anymore. Let's take this or finish up this conversation. We generally define steroid resistance as at least 3 to 4 months of high dose steroids. That is about 60 milligrams. If you're a pediatrician, I think Peshwan may be joining us, they use different criteria for defining steroid resistance in the pediatric patient. That's typically about 4 to usually 8 weeks of steroid exposure before they're prepared to call that steroid resistance. So it's clear that adults take longer than kids to remit in response to steroids in general, okay? And that's true for FSGS as well. So some of the early work on FSGS really made that distinction. It used to be the case that FSGS was thought to be very commonly steroid resistant, but then when practice patterns evolved and we were treating for longer courses, we found greater steroid responsiveness in FSGS, okay? Now, steroid responsive disease can then fall into some of these subcategories. You can respond to the steroid, and then after I've weaned the steroid off, you relapse, okay? That would be considered frequently relapsing minimal change disease. You can use some of these terms. There's a lot of cross-pollination across FSGS and minimal change. You'll see these recognizable labels when we talk about FSGS as well, and it helps you manage the patient. The purpose of labeling these patients in this fashion is it then shifts your mind to other therapeutics. Once you start to be characterized as frequently relapsing, for instance, you're starting to think to yourself, gosh, what are the costs of hammering my patient with steroids, we really need to be thinking outside of that standard therapy at this point. Okay. Steroid dependent patients are those that remit with steroids, but then as you're tapering the dose down, you develop a relapse. So they're dependent on steroids at some reasonable dose in order to maintain remission. Okay, so that would be the steroid dependent patient. Again, the bulk of patients with minimal change disease are going to be steroid responsive. If you have steroid resistant minimal change disease, question the diagnosis. We've made the point that adults take longer than kids to remit. And here's some statistics that you're provided here. The latency to remittance that I've provided you. Okay, there is some low incidence of spontaneous remission. In general, patients require treatment. Now, that's not the case if, for instance, I have a non-steroidal induced minimal change disease. You might just withdraw the drug, observe the patient for a while, as long as they're doing well, meaning they have preserved GFR, you're managing their edema with diuretics effectively. You might, in that instance, just elect for a period of observation and just withdraw the nonsteroidal if you're convinced that's what it's from. Okay, but otherwise, if without that inciting event, it's rare for there to be a spontaneous remission. We generally pull out the therapeutics pretty quickly. Okay, especially because in general, minimal change is quite treatable. Right now. These patients generally respond in complete fashion. And when you have a partial response, once again, you should be thinking about an alternative diagnosis, that is FSGS. Now, patients will relapse, and you need to prepare yourself for that, or to prepare your patient for that. So you should have them be on the lookout for signs of relapse. That usually happens within a year of tapering the steroids, but can happen even years down the road. We've had patients who have been in remission for greater than a year and then relapse at year 2 or 3. Okay, so certainly that can happen. In general, there is a trend towards less relapses as you age. So it is the case that some pediatric patients who have a course that is frequently relapsing during childhood relapse less commonly or permanently remit in adulthood. Okay, that is a pattern that's also described. ESRD is rare. We've gone over that a couple of times, that progressive CKD is not the common clinical course of a minimal change disease patient. And in the past, before we effectively treated patients with minimal change disease, these patients were dying of infections such as spontaneous bacterial peritonitis with pneumococcus. So these were patients that were predisposed to infectious complications from the nephrotic state, from the third spacing and ascites. But generally speaking, patients do generally well because it's a fairly treatable condition. Now, treatment is really to resolve the nephrotic state. Okay, let's extrapolate that principle across the 3 idiopathic syndromes. Again, minimal change, FSGS, and membranous. We're generally not treating those unless you're nephrotic. So if you're subnephrotic from your conservative therapies, you can call that a win. There's some controversy in FSGS in particular, where people have published worse prognosis with 2 grams of proteinuria versus 3, and I always get the question, well, what do I do with 2.8 grams of proteinuria versus 3.2 grams of proteinuria? Obviously, this is an arbitrary cutoff, and you have to make a decision based on the risk and benefits of your patient. But the general practice principle is if you're subnephrotic, you call that a win, okay? And you don't pull out the hammers that we generally hammer our patients with in order to treat these with medications with side effects. Okay. Now, for the initial treatment, we generally are using steroids. I don't go much more than 80 milligrams, even if you're a big person. I'm generally shooting for 60 to 80 milligrams. Okay. How long do we treat? If you're an adult, in children, we treat shorter. In adults, it would be reasonable to treat for at least 8 weeks. I'm choosing my words carefully because there is not a randomized controlled trial that defines the exact amount of treatment, the duration of treatment, even in the more common condition that we treat, lupus nephritis. We don't have randomized controlled trial data that tells you what you're supposed to do with the steroids, what you're supposed to do even with the mycophenolate for the duration of therapy. These are all, as I often use the term, art of medicine decisions, okay? But in general, people have shown in retrospective data sets that when you treat less than 8 weeks an adult with high-dose steroids, the relapse rates are pretty high. So in general, even if you remit within, let's say, 1 week of starting steroids, I'm generally committing to about 8 weeks for that first episode. Now, as people accumulate relapses and are less and less tolerant of steroids and have more cumulative side effects of steroids, their risk of bone loss and cataracts, if I keep going for 8 weeks at a time, that cumulative risk, well, accumulates. And so I don't necessarily commit to 8 weeks every time I'm putting you back on the horse. But that first episode, I'm pretty committed to 8 weeks. Again, because there is an increased risk of relapse in the adult that is treated for shorter courses than that. Okay. Generally, again, I'm at least 8 weeks and about 2 weeks after the remission. So let's suppose I hit, I'm at 7 weeks. I remitted at 7 weeks. I'm going to keep kind of going beyond 8 weeks. Is it going to be, 9 weeks? Probably not. I might be, drawing it out to maybe 10 weeks at that time or 12 weeks. It really depends on how my patient is doing. So that, again, is an art of medicine decision, how long to treat. What I want you to take home is that 8 weeks is probably something you should commit to in that de novo patient, okay, because of the increased risk of relapse with shorter courses. Now, again, we don't go longer than 12 to 16 weeks, right? At that point, I'm calling it steroid resistant. I'm considering the alternative diagnosis of FSGS, and I'm looking for other tools. The most common of which is going to be my calcineurin inhibitor. Going back to the big three, if you think about minimal change FSGS and membranous, you'll find calcineurin inhibitor therapy exists in the treatment algorithm for all of those. And even if I'm to bring in lupus membranous, calcineurin inhibitor therapy is a reasonable second line or even first line for these conditions, right? You can even make the call, as we've done before. I have a minimal change patient who has acanthosis, who had peripartum or diabetes during pregnancy-induced diabetes. I'm not going to be enthusiastic about giving a patient 60 to 80 milligrams of prednisone. I may say, okay, let's just do a calcineurin inhibitor out the gate. Okay. So once again, think calcineurin inhibitors broadly as a tool across your idiopathic nephrotic syndromes and even, secondary membranous and lupus. Okay. Yes.
With the patients that have like a lot of complications from steroid use or like vascular necrosis, there are sometimes protocols.
Oh, I didn't realize I did that. What?
Regarding the use of calcineurin inhibitors with like to try to decrease steroids or to try to help with tapering if you don't want them to be on like higher dose.
Can you repeat the question?
Or just in regards to using calcineurin inhibitors
Yes.
for trying to help with tapering of steroids if you don't want them to be on as high or using it as an additional region.
So it's okay, Langdon. It's water. It'll dry. It's so far so good. The question is, I'm sorry, my attention is kind of directed in multiple directions. It's just when should I use, just more clarification of when should I use calcineurin?
Use calcineurin if you're wanting to reduce steroid use, or if you want to consider on reduction in steroid use.
Yeah, I mean, if you can think of any reason, like active infection, like where I don't want to give a bunch of steroids, then calcineurin inhibitor is a reasonable consideration. Let me leave it this way, okay? I have met only one patient with minimal change disease or even steroid responsive FSGS that is not calcineurin inhibitor responsive. So calcineurin inhibitors in general work for steroid responsive nephrotic syndrome. Okay? That makes sense?
Yeah.
So I have, I don't feel committed to, oh, I got minimal change disease, I need steroids. If I have an excuse to not use steroids, whatever it may be, right? Then I won't use it, right? If my patient can't tolerate, let's use this. It's kind of a soft. My patient just can't sleep, very nervous, and just says, "Doc, I hate this. I can't do it. My acne is just going nuts." And then I'll just say, "Okay, let's switch you to a calcineurin inhibitor." Now the response is slower, but if in general, if you've got steroid responsive nephrotic syndrome, that is steroid responsive minimal change or FSGS, you're going to respond to calcineurin inhibitors. And the only instances where I see that not happen is that I have subtherapeutic dosing. I've inherited patients from the community who said, "Oh, I've been labeled as steroid resistant and calcineurin or steroid responsive and calcineurin resistant." I don't even believe that. I generally say, "Well, were they checking levels? What levels were you getting to?" And those are generally patients who we just didn't get a therapeutic level on. Okay. So the summary is, again, calcineurin inhibitors work in minimal change. Calcineurin inhibitors work in steroid responsive FSGS. So if you have an excuse to use them, you can use them. Yeah, the question is, what are the calcineurin targets that I'm trying to achieve? If I had to give you kind of a working range, it's between 3 to 8. I don't really push too many to 8 to 10. But if I have somebody in the early phase, I'm going 5 to 8. And when they're in remission and I'm on year 1.5, or even past 1, I'm going in the sort of the 3 to 5s in order to avoid the chronic calcineurin inhibitor toxicities. And then 5 to 7 for kind of the middle ground. But I'm pushing maybe 7 to 8. I don't really go more than 8. All right, and then if cyclosporin, I use cyclosporin too, and so if you're using similar boundaries, a 50 is low, a 200 is on the high end, so that's like your 8s, and then the 150s are in that 125 to 150 is in that middle sort of like your 5 to 7 on FK. Okay. All right. In particular, some people who have a frequently relapsing course get in the habit of even self-monitoring. They'll buy dipsticks from Amazon, which you can buy, and detect proteinuria early, and they even have a habit of self-titrating prednisone, so they can put themselves on moderate doses of prednisone when they notice an increase in proteinuria. That is a strategy that is used, particularly in the pediatric patient or even the frequently relapsing adult. But again, frequently relapsing is more of a pediatric presentation. But that is worth considering. I've used it in a minority of patients. And then, if you have your first relapse, granted, if you haven't accumulated toxicities, you can reinitiate prednisone. Okay, but once again, you individualize. If you can't tolerate that, or your patient is 100% against that, calcineurin inhibitors work. Okay, for minimal change disease. Now, for steroid-resistant disease, we'll broach that as we talk about FSGS, because I view that as a FSGS, not steroid-resistant minimal change disease. Okay? Now, when there is contraindications, either absolute or relative, or if I have the frequently relapsing patient, or if I have steroid-dependent disease. So again, the labels that we're using are to help you manage the patient. So that's why we use the labels, not simply to quiz you. So when you are encountering these sorts of phenotypes, that's when, again, you consider the calcineurin inhibitors, okay? Now, you can add the steroids, right? And you can add the calcineurin inhibitor as well when you need to turn the corner quickly, right? I would not rely on a calcineurin inhibitor in somebody who has, weeping legs on torsemide 50 BID. I'll say, okay, well, I'm going to put you on a calcineurin inhibitor, because those take 3 months, really, to 2 to 3 months to be turning the tide on the proteinuria. You need early relief of that kind of presentation. So you may consider in that scenario steroids plus the calcineurin inhibitor. Once they get into remission, you peel off the steroids fast. You don't have to commit to 8 weeks or 16 weeks. As soon as they get into remission, and as soon as I have a therapeutic calcineurin level, I start tapering that steroid. Okay. In general, my practice pattern is, if you have any of the idiopathic nephrotic syndromes or a lupus membranous, I'm deciding to treat with a calcineurin inhibitor, that is a 2-year commitment. Okay. Where does that come from? Well, there's small randomized controlled trials on the use of calcineurin inhibitors in membranous nephropathy, and they show, a high relapse rate. Okay, this is membranous nephropathy, a high relapse rate. If you treat for 6 months, you will have a relapse rate of 50% if you peel it off after just 6 months of therapy. Okay, which is a reason I gripe a lot about the Mentor study when we talk about membranous nephropathy, because it was compared against a standard treatment arm that was designed to fail. And the primary author of Mentor did the work in membranous nephropathy on calcineurin inhibitor. I can't say for certain why he would have designed the trial like that. He knew he had to know that would have been an inferior arm. In any case, again, it's a commitment of 24 months. So I prepare my patient for that. 2/3 of the patients, again, will relapse in minimal change disease for these shorter courses of treatment. I've given you some data in the membranous space. Rituximab seems to be a reasonable intervention, and you can do the monthly ×4. I've always done the 1 gram ×2 for obvious reasons. It's just easier. And this is a drug that is, the way I use it in general, in minimal change in FSGS, is to keep people in remission. I don't use it as monotherapy in order to get a relapsed patient or a new presentation into remission. Okay, I generally, it's pretty reliably a good steroid sparing drug, or even calcineurin sparing drug. So you get them into remission with your CNI and the steroids. The rituximab can be used to keep them in remission and take those away. Okay, so I think of it primarily as a steroid or calcineurin inhibitor, or a maintenance agent, let's say, as opposed to an induction agent. Now, people have used it to get people into remission, but it's clearly less effective for that. Some of that may be through pharmacokinetics, because when you're floridly nephrotic, rituximab is cleared more readily. It is a protein, so your half-life is shortened, your degree of sustained B cell depletion is shortened, and people have shown as well in the lupus nephritis space that proteinuria predicts rituximab responsiveness in the lupus nephritis space, presumably related to the drug clearance or the pharmacokinetics. That being said, we still do use rituximab in floridly nephrotic membranous patients, a la the Mentor trial. Okay, so it's not all pharmacokinetics, but again, generally speaking, I view rituximab as primarily a maintenance agent, not an induction agent. There are old papers using cyclophosphamide, primarily in the children's literature, as steroid-sparing agents for frequently relapsing patients. Once you're pulling this out for a steroid-resistant, what is presumably an FSGS or undersampled FSGS, you're really throwing Hail Marys, okay? So it shouldn't be something at that top of mind. Mycophenolate is something you can try. The data for its usefulness is poor. We have, I believe, 2 or 3 mycophenolate responsive idiopathic nephrotic syndrome patients. In general, mycophenolate should not be in your toolkit for idiopathic nephrotic syndromes. In fact, I'll go further to say, although it seems one of the most commonly used drugs across multiple GNs, it is really only proven in lupus. Okay. There's a recent paper in IgA nephropathy that shows in a randomized control trial it's beneficial in Asian patients with IgA nephropathy. There's a small study for maintenance agents in ANCA vasculitis, very weak studies in comparison to what we have in lupus. So even though people feel most comfortable with mycophenolate, and I get a lot of people in the community who gets referred for second opinions on mycophenolate for random GNs, it's generally not your go-to except for lupus, okay? And then there's these various sort of sustained slow taper protocols where you initiate prednisone for the frequently relapsing patient, and then you slowly taper it. You even might use alternate day dosing strategies. That's used more commonly in pediatrics, where they're giving alternate day dosing of steroids in order to try and balance the risks of prolonged steroid exposure. Okay. Moving on to FSGS, if there are no questions. All right. So this is, again, one of the 3 what we call idiopathic nephrotic syndromes, but it's a very mixed bag. So FSGS really isn't a diagnosis, it's a pattern. And we've gone over some of those adjectives yesterday when Mustafa reviewed for us the difference between focal versus diffuse, segmental versus global. And so focal segmental glomerulosclerosis is telling you that you have glomerulosclerosis, a scar, that is focally distributed, less than 50% of glomeruli, and within each glomerulus is involving less than 50% of the glomerulus, that is segmental. So this is just a description of a pattern, okay? And there's multiple different ways you can manifest FSGS. In general, we use one label where we call it adaptive FSGS, okay? This might encapsulate one dimension of secondary FSGS, okay, where the kidney is adapting to a hyperfiltration demand that is asked of it. Some of those demands may come from body habitus, including bodybuilders. This is kind of described in the bodybuilding world, where these individuals are predisposed to secondary FSGS. Anything that knocks out functional nephron and leaves the remaining nephron to pick up more of the homeostatic demand can result in this so-called adaptive FSGS. This is basically an acceleration of the senescence of aging, right? If I biopsied an 80-year-old for hematuria, it's very likely I'm going to see focal sclerosis there just from the aging process, okay? And so this is an sort of an accelerated aging process that might result from reduced renal mass. This is also a feature of sickle cell disease. Exactly how that happens is not quite clear. We suspect that sickling in the deep medulla results in ischemia and then a vasodilation of the afferent arteriole in response to that medullary ischemia and hyperfiltration, okay? Similarly, cyanotic heart disease, right? This would also be a situation in which I have ischemia in the deepest parts of the nephron, and then an adaptive hyperfiltration response to that ischemia, resulting in eventual secondary scars and proteinuria. This may be present after bouts of severe preeclampsia. This may be from any cause, even like severe ATN, years down the road, can result in these secondary scars, lupus, burnt out lupus. So when we're talking about lupus in the clinics, you might hear us say, "Is this proteinuria from lupus or from secondary FSGS?" And that would be a situation in which we think it's all burnt out, it's inactive, but now we have the secondary scars. And sometimes you have to rebiopsy in order to make the determination of whether you need to continue immunosuppression in those patients. Okay, so that's one form of FSGS. The other is, and then I'll finish up the secondary FSGS, and then we'll go to primary FSGS. And we really only think about treating with immunosuppression when we're dealing with primary FSGS. Let's finish out the secondary FSGS category. Viral infections are associated with these and often are associated with the collapsing variant. This includes COVID, HIV, parvovirus. These are well described now as causes of FSGS, particularly the collapsing variant of FSGS. And there are other viral associations as well. People have described post-COVID vaccination collapsing FSGS as well. So those are all causes of FSGS as well. Okay, drugs. Heroin nephropathy used to have a place in our lexicon. This is probably a lot of HIV-associated nephropathy before HIV was discovered. But there may be adulterants in heroin that predispose to podocyte injury and precipitate FSGS as well. Pomidronate, bisphosphonates in general have been associated, but most prominently with pomidronate. We have a case report that we reported here of zolendronate-induced FSGS. So it's been described, but it's generally with pomidronate. We don't use much interferon anymore, but that is also a predisposing factor. And Danny talked to us about even a model of studying APOL1 biology where mice transfected with the APOL1 high-risk alleles were given interferon in order to precipitate proteinuria. Lithium is associated with FSGS as well. And then there's some associations with some of the connective tissue diseases. We have a lupus patient, for instance, who presented with collapsing FSGS. He also has blanking on macrophage activation syndrome as well. So, there is a immunologic precipitants for this FSGS, particularly the collapsing form of FSGS. Okay, so primary FSGS, on the other hand, refers to this FSGS that has some as yet unidentified permeability factor that's circulating in the individual, such that, if you give me a new kidney as a kidney transplant, I might even start developing proteinuria in that new kidney. Okay, I have something circulating that causes this leak of protein. We don't know what that is. There was some enthusiasm over a molecule called SUPAR, but that has since been much less enthusiastically, uh, much less a candidate inciting cause. So what is the epidemiology? If we can backtrack a little bit, this is a common form of nephrotic syndrome, especially in the Black patient, okay? And that probably has that APOL1 risk allele backing it, in increasing the prevalence of FSGS amongst Blacks. And it is really the most common GN that is associated with ESRD, even though it's still a small proportion of the ESRD population that is listed as FSGS as the primary diagnosis for their cause of ESRD. But still, it has a sufficient morbidity that we need to pay attention to it, and we need to push progress forward in how we treat FSGS, because we're still very limited in our therapeutic skill in approaching this problem. Yeah, this is based on the 2728 form, which is is a messy, it's like looking through your problem list in Epic. Half of them are true. Some of them were true, 10 years ago. So this is based on again, someone's filling in a bubble on that 2728 form. If you're not familiar with that, that's what you have to fill out when you have a new ESRD patient. This is a form that you put in there, some of their demographic information in, you put in their, diagnosis as a cause of ESRD. Doesn't require a biopsy. You just put in your best guess. All right. FSGS, I told you again, encapsulates these multiple different underlying factors. We didn't yet talk about the inherited forms of FSGS, which I'll go over here shortly. And then we don't have to belabor the association between FSGS and APOL1 risk alleles. Danny taught us some of that fairly recently. As well as the prevalence of this amongst African Americans in the U.S. This is around 15% of African Americans that carry this two APOL1 risk alleles. Now, moving to the inherited, in general, these are podocytopathies. That is, they're genetic defects in podocyte biology. But that's a bit of an oversimplification. But that's where the focus lies, okay? The earliest genetic forms of FSGS are associated to these important proteins for the podocyte slit diaphragm, nephrin and podocin. This nephrin mutation also refers to this congenital nephrotic syndrome of the Finnish type. This is a really debilitating nephrotic syndrome that happens in early infancy, even before 2 months of age. Podocin mutations happen a little bit later when they've been described. They can even present in young adulthood. But that is one of the other, that's the second genetic form of FSGS that was described. There are multiple other genes that are associated with genetic FSGS, okay? And I've only categorized the general categories, or I've listed the general categories of some of these genes. Many of them have to do with podocyte biology, including the integrity of the cytoskeleton And that makes sense. As you visualize the podocyte, it is a very complicated cell with primary and secondary and tertiary foot processes. It requires an intact cytoskeleton in order to function normally. Okay, and so people have described cytoskeletal genes that are mutated in genetic forms of FSGS. They're signaling molecules, they're metabolism molecules, and there are genes that code for matrix proteins that are also associated with FSGS. Okay, there's a long list, at least 40 to 50 now, that have been described as associated in various degrees with FSGS. Some are really solid, some are sort of loose associations, but it's fairly complicated. And you should be thinking about, even though it's our pediatric colleagues that think primarily about in genetic forms of FSGS, you as an adult nephrologist should also be thinking about genetic forms of FSGS when you have somebody who's truly refractory. Now that we have renocite testing, you probably can be more proactive about identifying patients who have inherited forms of FSGS. Okay, because they can still present. You don't have to present in childhood. People have described forms of FSGS, including this actinin, which is a cytoskeleton gene that is described as presenting in young adulthood most commonly. Okay, so I think I've said enough about that without bogging down with too much detail. The take-home message again is, as an adult nephrologist, you should think about inherited forms of FSGS when you have somebody who is really refractory to all of your treatments. I don't test everyone. I generally, unless you have a positive family history that's unusual, I reserve testing for those who are refractory to treatments.
Benefit of knowing that would be stop.
Yeah, you won't hammer your patients with a bunch of immunosuppression if you're dealing with an inherited form of FSGS. And if you did a transplant in those patients, you would generally have a low risk of relapse. Post-transplant recurrent FSGS should be low, although it's described. Some people have described genetically proven FSGS that has relapses post-transplant. In those cases, there may be an autoantibody that's produced to the new, podocin. So it's in that case not a permeability factor in the mysterious sense. It is an old-fashioned antibody. Okay. All right, pathology. So there's a variety of forms of FSGS that we describe. In general, you need a solid biopsy specimen in order to be relatively confident that you're not undersampling. 8 is pretty modest. I think you have more confidence when you're getting 20 glomeruli in making the diagnosis of FSGS. So when people have debated, does nephrology need to do kidney biopsies? I had recently had a conversation about this with a fellowship applicant. I believe we add value because we can decide based on our differential diagnosis how much tissue we need, and then other considerations. But this would be another example of why, a clinician, a nephrology clinician, I think adds value when they're doing a biopsy. If they're looking for certain diagnoses, they know, that they need to be liberal with obtaining tissue, for instance. I hear a group assembling outside, so I can't go over too much. Let's see if we can at least go through these pathologies and then end it there. All right, so all of these share in common the focal scar, okay? And you can describe that in multiple words, but you see it, okay? You see it with this, staining of excess, let's call it matrix, okay? And then there's often another feature to not overlook, attachments between the glomerulus and Bowman's capsule. These are called synechii, okay? You can have nonspecific IgM deposition. IgM is a large immunoglobulin and is sticky, and it gets stuck on these, these areas of excess matrix, okay? So in areas of sclerosis. Now, your variants of FSGS include just what we call FSGS not otherwise specified. Here would be an example of that. Here's a PAS stain. Here's a focal scar that we would potentially call just FSGS not otherwise specified. The collapsing form of FSGS is one of dedifferentiation and proliferation of podocytes. So, we typically think of podocytes as terminally differentiated cells, but for some reason, in these patients with collapsing glomerulopathy, they develop, because of, for instance, APOL1 risk alleles and then HIV, their podocytes dedifferentiate and increase in number, and then fill, basically crush down the glomerulus, and then it is collapsed. So that would be the feature of collapsing glomerulopathy, and you only need a single glom to make this distinction. If you don't need multiple gloms that are collapsed. If you found one collapsed glomerulus, then you might make the diagnosis. Sometimes it's challenging distinguishing these from crescents, but just think of, is my cell proliferation from the inside out, and therefore there's these gaps between those proliferative cells and Bowman's capsule, or is it encroaching from the outside in? That would be a traditional ANCA crescent, okay? Now, you generally have these proteinaceous droplets in the dedifferentiated podocytes as well. Don't forget that this is not only a glomerular pathology. It's very common to see tubular changes as well. Some of this same dedifferentiation and hyperplasia occurs in the tubules, resulting in large dilated tubules that is very commonly seen in collapsing glomerulopathy. Okay?